Assalamu alaikum. Our next session will be an interactive session. Would like from the audience and the participants to go to the link so they can interact with the voting for the result of the questions from the presenter. The first speaker will be Dr. Raed, his assistant professor in Hospital University Cuba. He graduated from Madina Master in 2006. He's a gastroenterologist. This case will be an interactive case discussions. So please from the participant to go to the link from now in their phone. Welcome to the round.
Thank you, Dr. Mahdi. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه المنتجبين. First of all, really, I'd like to thank the organizing committee for giving me this great honor to present in this very interesting and important meeting, especially to Dr. Ahmed, really, who do a great job here in organizing this meeting, and also extend my thank to ABFI for their effort. Now I think this is time to try to transfer our knowledge into practice. We learned a lot during those 2 days. Yesterday from Dr. Nahla and today Dr. Shakir. They're presenting a lot of data and how to approach patient with Crohn's disease and how to apply, treat, to target, and to do the time-bound management. As you know, Crohn's disease really it's a spectrum of disease. Patient, they are not really the same. One Crohn's disease is different from others. So we cannot really apply all the management to the same management to every patient. We have to choose a prognostic factor in each patient in order to select the most appropriate treatment. We cannot start biological therapy early in every patient. It's not cost effective, as well as you know from manipulation-based study, roughly half patients of Crohn's disease they actually have mild course and they will not require biological therapy. So the aim of this presentation is to discuss really how to select the prognostic factor in order to help us as a gastroenterologist to decide the treatment. Those are really a real case scenario. So I will start with this lady, Lee. And what gonna to do here, I will present the data and we'll present certain element in this patient history, and I will ask you as an expert to tell us what do you think. If this really factor is important, it will help you to stratify your patient into high risk or low risk, or it has nothing to do with stratifying your patient. So we'll go over this case. This lady Lee, she is 19-year-old female. She is from Canada and who's studying biological science at university. She is non-smoker and has no relevant traveling history. So these are brief data. So the first factor, as you can see here, there are many factors. I will ask you to choose if those factors are non-predictor or predictor to worse prognosis or predictor to a good prognosis. So we'll start first with the age. And from your website, I think you can vote for it. So for the age, we'll start. The age for this lady, as you can see, she is 19-year-old at the diagnosis. So what do you think? Age, is it important? Give a favorable outcome, 19-year-old, or poor outcome, or non-predictor? Wow, this is really. في بعض المتردد. This is final? Final, okay. So we have 73% saying that age less than 19 is a poor outcome, and 27% saying that it's favorable outcome. Okay. So we'll go with the vote. Of course, we'll know the answers at the end of this presentation. We'll choose the age according to your vote into poor outcome. Great. So the next element in her history, she has no evidence of extra-intestinal manifestations. So she has no evidence of extra-intestinal manifestation. So what do you think about this? This shows a favorable outcome, poor outcome, or non-predictor. So you can vote, please. So it's great. Okay, 91% said that it has a favorable outcome. We'll go here. Okay, third element, Miss Lee, family history. She has no family history of inflammatory bowel disease. So no family history of, what do you think about family history in patients with inflammatory bowel disease Crohn? Would it affect your, or would it stratify your patient to high risk or low risk, or has nothing to do with as a predictor? So please can you vote for that? Okay, here we can say there is a 50-50 between not prognostic or favorable outcome, but more maybe toward 50% toward not. Okay. So what do you think?
Also, you should pick the highest figure.
But if highest is none, صح? Okay. What do you think? Chairman, you can vote for. So I think your voice is for 2 voices, is it? So we'll leave it as non-predictor. Okay, good. What do you think about education? Miss Lee, her education, she is, as you know, she's a university student, so she considered to be educated. So whether education considered a part of prognosis will affect stratifying the risk of your patient, will alter your management plan? So she is a education high. So favorable outcome. Okay, we'll see. So we'll choose for education, that will choose favorable outcome. Perfect. Lifestyle. From her lifestyle, she is a non-smoker. So patient, inflammatory bowel disease, Crohn, and she is non-smoker. What do you think? Is this good? Okay, it's 100%. It's an amazing vote. Nice. So we go for lifestyle. This is a favorable outcome, non-smoking. Okay, so she had endoscopy in her initial presentation, and the endoscopy it shows 2 lesions, one of the sigmoid colon and one of them in the transverse colon. So her colonoscopy shows epithelium to be ulcerated in the transverse colon and sigmoid colon. Small anal fissure is present, and the ileocecal valve and the distal ileum both appear normal. So it's mainly large bowel disease, but the description of ulcer, as you can see here, it's a deep ulcer in the sigmoid colon, and the other one, transverse colon, also multiple deep ulceration, and there is an anal fissure. But the small bowel looks normal. So based on this findings or presentation, what do you think based on the colonoscopy? Would it be a favorable outcome, poor outcome, or non-predictor? Colonoscopy shows lesions only in the colon, deep ulcer in the colon, but normal small bowel. Excellent. So we have the majority vote toward poor outcome. We'll take endoscopy into the poor outcome. Great. Histology. So as usual, we get the biopsy from this lesion, and it shows that deep ulceration from the histopathology present in the mucosa and submucosa, dense inflammatory infiltrate consisting of chronic inflammatory cells in the mucosa and submucosa. No granuloma seen. Rectal mucosa has mild inflammatory cell infiltrate only with no ulceration. Appearance is consistent with inflammatory bowel disease and favor Crohn disease. So based on that histological findings, there is anything to support poor outcome or favorable outcome based on histology, or it has nothing to do with it or cannot predict? Histopathology in Crohn disease. Excellent. Yeah, no wonder they are expertise of the field. So we'll go histopathology. We'll leave it here, non-predictor. Okay, imaging. So she had MRE as part of her evaluation or the investigation, and the picture of MRE actually consistent with what we found in colonoscopy. Revealed extensive deep ulceration of the colon with patchy involvement. The sigmoid colon and transverse colon also appear to be involved. And here the small bowel also was normal. This is based on MRE. So giving this picture from radiological evaluations, what do you think about radiology here or imaging? Would it help to stratify also your patient into poor outcome or favorable outcomes? MRE showed deep ulcerations in the transverse colon and the sigmoid colon. وقف 50% favorable outcome. MRE showed the deep ulcerations. Okay, so 50% safe. What do you think, Dr. Mahdi? Favorable. Favorable. Okay, we'll go to favorable outcome. Okay, so in order to assess the disease activity, we use the, as you know, the Harvey, the Blatchford score. Here, her score actually was showing moderate risk, or maybe moderate stratification. Her patient general well-being very poor, and abdominal pain for the previous day was moderate. Number of liquid stool per day was 5, so she scored 5. There is no abdominal mass, and she has only from the complication anal fissure and aphthous ulcer. So total score of 12. So according to the rating here, as you know, from Harvey Bradshaw score, 12 indication of moderate disease. So according to this score, she has moderate disease. So for using this score, what do you think is it a good marker for prognosis? It can label your patient whether they have high risk or low risk region. So you can tell us, please, from this. Sorry, this. Okay, so based on that score, which has no non-predictor, favorable outcome or poor outcome of 12. Poor outcome, 17. Okay. We'll go with the voting into poor outcome. And last element of those factors is a treatment. So as for her initial presentation, she was started on systemic prednisone prescribed for the patient on the first visit. So she has systemic steroid started. This is her first presentation. So this information, would it help you to stratify your patient and to have favorable outcome or poor or non-predictor, starting systemic steroid? Okay. So yeah, we'll go. Majority say that this is an indication of poor outcome. We'll go to poor outcome. Perfect. So again, let us make sure about our answer here, or your voting. The non-predictor is family history and histology. Favorable outcome, no extraintestinal manifestation. She has university or high class education. Lifestyle, there is no, she's non-smoker, and there is an MRE findings of deep ulcer in the transverse and the sigmoid colon. So those are favorable outcome based on your voting. Poor outcome, young age group, deep ulcer and endoscopy, and high score, as well as starting on steroid. So based on those evaluation, what do you think overall stratifying your patient? Would you consider this patient as favorable outcome or poor outcome overall evaluation now, based on all those factors? Whether she has poor, you choose already 4 element: age, endoscopy, HPI, and treatment. So she will be poor or favorable outcome. Okay, so overall poor outcome. Okay, excellent, poor outcome. Good. So now let us see what's the correct answer. Okay, so I'm going to present the correct answer according to the expertise recommendations or evidence available. For the age, it's correct, agree. Age less than 16 or age less than 14 considered to be really an indication of high risk. So any patient with inflammatory bowel disease diagnosed at age less than 40 considered to have really a high risk for complications within the 5 years from the diagnosis. Her age here is 19, so this is considered to be a poor prognostic factor. The second thing, absence of extraintestinal manifestation. Yes, this is really a good prognostic and put your patient into a good, favorable future because presence of extraintestinal manifestation really make her at higher risk. Family history. Most of the data really show that family history not affecting really the prognosis. But there are data supporting that if there is one member of family has a Crohn's disease, there are higher chance of surgical complication in this patient as well as higher chance of intestinal failure than a sporadic case. But this data is really not strong, so they are not considered as a prognostic. Education, actually, they said that education can improve the compliance of the patient, but it is not really considered as a factor to stratify your patient to high risk or lower risk. It can help to your patient to be more compliant, but actually it's not really a factor for to stratify your patient to whether it's higher or low risk patient. So this is really an incorrect answer. It should be non affecting the outcome. Lifestyle, totally agree, or the smoking. Absence of smoking or presence of smoking put the patient into a complication of the disease. Also, they are at higher risk of dose escalation, higher risk of surgical complication, and higher risk also of surgery. So smoking is one of the really poor prognostic factor. Endoscopy here, presence of deep ulcers in the colon considered to be really a high risk for developing complications, as well as small bowel lesions. So here, this patient, she has a deep ulcer in the colon, and this considered to be a high risk or one of the worst poor outcomes. So that you're correct here is correct. Histology, actually, it is non-prognostic, as said correctly. It can help to diagnose the case, but will not really put your patient into higher risk or low risk, even though now there is a data saying that the histopathology and early diagnosis of inflammatory bowel disease can stratify your patient into either penetrating inflammatory or structuring disease, but wouldn't affect the prognosis. Regarding imaging, the same thing applying to endoscopy, actually, it's applied to imaging. So if patient with imaging showing that there is a deep ulcerations or in the colon and sigmoid, they are considering really as a prognostic factor in patient with inflammatory bowel disease. So imaging, yes, it will give you really a favorable or poor outcome. So here the answer should be really yes, it should be one of the poor outcome. Regarding the score, the score can help to stratify or to tell you the activity of the current presentation. But the studies show that it wouldn't really affect or wouldn't put your patient into higher risk of complication or not. Only it's important for the active presentation rather than as a factor for worse prognosis. And the same applied for Crohn's disease activity index. The treatment, the answer really is correct that starting steroid in the first presentation, this is really a poor outcome, and this justify your patient that will run most likely complication in the future. So here, according to the scenario for this patient, the presence of those four factors, totally agree, it put your patient into a poor outcome and high risk Crohn's disease patient. So what happened to the real scenario in this case? After starting her steroid and follow up after 12 weeks, patient is still really actually symptomatic. They cannot taper her steroid, and azathioprine was started. Again, after 12 weeks, she failed to be controlled, and anti-TNF was started, and she was achieving really a good remission after 1 year. So this is regarding this case for prognosis. If you have any questions or
There's one more question, Dr.
I think.
Will you advise to use this score for your patient assessment?
Which one?
Will
I think we done.
Will you use this score assessment for your assessment of your patient as a voting from the audience?
Which score?
This is score system.
Yeah. For me.
I mean, would you
Okay.
utilize
I'll do this question.
this application?
So 100% yes. Okay. This is great.
You convert us.
But here I cannot really control it from the screen. I think that's it. This is the end. Huh? Okay. Thank you. اوكي
دكتور وليد شمراني.
دكتور وليد. Walid is consultant gastroenterology in National Data. We'll have also another interactive case discussions now.
Yeah, sure. Thank you, Dr. Mahdi. Thank you for the organizing committee for inviting us, and it's always yeah, thank you. It's always great to be in Al Madina. Okay, can you hear me? No? I don't think it's really working. It's clear or no? Okay, good. Okay, so we will go through some management decision in a case that is, inshallah, will be fruitful for all the lectures and information we took yesterday and today. So this is Mr. Jonathan Smither. He's 20-year-old male studying business marketing, Canadian-born, and father of British descent, and mother Ukrainian descent, lifelong non-smoker, and occasionally he smoked cannabis. So he presented to the family physician in June 2016 with a 4-month history of increasing abdominal pain in the right lower quadrant and loose stool 4 to 6 times per day with a 3 kilogram weight loss. This is his first visit to as a referring physician. No family history of inflammatory bowel disease, 2 cousins with celiac disease. He has mild intermittent arthralgia in the right wrist and bilateral knee, but attributed to playing tennis, previous appendectomy at age of 13, and fracture of the right clavicle at age of 15. He doesn't use any medication, and a patient has full medical insurance through his service. So he has 4 to 6 loose bowel movement per day, no nocturnal symptoms, no rectal bleeding, no urgency, no tenesmus. He has dull, constant right lower quadrant pain, intermittent pre-umbilical cramping 1 hour after meals, lasting for about 20 to 30 minutes. He has painful right wrist, bilateral knees, and he lost 3 kilograms over the last 2 months. He has tenderness in the right lower quadrant and tender right wrist, no edema, no swelling, and no other intra-intestinal manifestation. So this is his blood work. It shows hemoglobin 132, white blood cell 9.4, platelet 392, and albumin 36. C-reactive protein is normal, 5.2. Fecal calprotectin is 740. And he has ferritin 124, serum iron 18, transferrin 1.98, and ALT 38, GGT 57, alkaline phosphatase 88, and bilirubin 21. TPMT is normal for this patient. So what does come to your mind first from the history? It's inflammatory bowel disease, but does it favor Crohn's more or ulcerative colitis? Just from the history, I think you can see it's favor Crohn's more because there's weight loss, loose stool, no blood, and also the pain, right lower quadrant. However, this patient underwent colonoscopy, and in colonoscopy there was a deep serpiginous and broad-based ulcer over the last 3 centimeters of terminal ileum with luminal narrowing with no stenosis. Colon was normal otherwise from cecal pool to the anal verge. So you can see here in the picture the deep ulcer in the terminal ileum. So next step, he underwent small bowel ultrasound, which is commonly used now to assist the patient, and found to have over 40 centimeters of the terminal ileum. There is mural thickening up to 7 millimeters. In this segment, there is luminal apposition, but no stenosis or dilatation of the upstream bowel. And Doppler show increased flow in the segment consisted with moderate to severe active Crohn's disease. You can see here the thickening and the increased blood flow in the ultrasound. So, what are your treatment goals for this patient? You see your phone, please, and vote. Yes, 100%. And the treat to target strategy actually is not only resolution the symptoms is important, is also achieving mucosal healing, and also by that not only colonoscopy but also to follow up the laboratory markers or parameters because they correlate with the symptoms and the mucosal healing. If you choose, for example, resolution of the symptoms, there will be disconnect between the symptoms of the patient and the actual inflammation disease. So that's actually the right answer. Do you discuss the treatment goals with your patient? So this is an easy question. So obviously, yes, patient should be involved. Not only discuss with the patient that you're not treating only his symptoms. Even if he's asymptomatic, you have to treat the disease itself. And tell him sometimes we need to escalate, we need to interfere, even if you feel completely fine. Patient has the right to understand that. So the diagnosis is discussed with the patient. His Montreal classification is noted to be A2 because his age between 17 and 40, L1 because the location in ileal, and B1 because it's behavior according to behavior inflammatory. And he is provided with educational information, which includes detail to the nature, history, medication options, surgery, and diet. And he is introduced to a member of multidisciplinary team. Vaccination letter is sent to his primary care physician, and goal of treatment ranging from symptoms control to mucosal healing are discussed, and he agrees that control of the disease is important as feeling better. Monitoring strategy are discussed as well. So what therapy would you initiate in this patient? Can you please use your phone and vote? Okay. So there are some answer with anti-TNF. Actually, anti-TNF, usually we use it as, a step-up strategy in case of conventional therapy failed, which is a steroid and azathioprine. However, if the patient is in severe disease, yes, you can use any biologic, especially anti-TNF as a first line. But in this particular case, he's not in severe inflammation. Therefore, corticosteroid and immunomodulator to maintain the remission are excellent choice for this patient. So he was started in prednisone 40 milligram daily for 2 weeks with taper of 5 milligram per week. He's started on azathioprine 175. Remember, his TPMT was normal, so he was starting full dose. And he's given a requisition to have CBC liver profile, albumin, to be done weekly for the first month, then monthly for the next 3 months, and then every 3 months. He's given an appointment to come back to the IBD clinic in 4 weeks. How will you monitor short-term, 3 to 6 months, in this patient? Symptoms, endoscopy evaluation, imaging, or biomarkers? Okay. Still going or stopped? Okay, so yeah, as the majority of you choose biomarkers is the right choice. Remember, symptoms, there is disconnect, as we said, between the symptoms and the inflammation itself, the disease severity itself. Endoscopic evaluation is I will accept that as a valid answer. However, it's intervention. Patients usually they don't tolerate this much of endoscopy in just short time. Imaging, same thing. If we choose CT, he will be exposed to radiation. MRI usually is not tolerable for the patient, so we don't use it as frequent. Ultrasound is good, but it's operator dependent. While biomarker, they correlate with the mucosal healing, and you can use it safely to follow up the patient. So the right answer is biomarker. So the patient returned at 4 weeks, feeling well, in prednisone 30 milligram daily and azathioprine 175 milligram daily. He's instructed to continue to taper his steroid, and he's given a requisition to perform fecal calprotectin in 8 weeks. And recall his CRP was normal despite active endoscopic disease. So this patient is non-CRP producer. You have some patients like that. Their inflammation doesn't correlate with the CRP. Therefore, CRP is not a reliable biomarker in this individual patient. He's given an appointment to come back to the IBD clinic in 8 weeks, and he returns from his appointment on azathioprine. He has been off prednisone for 2 weeks, and he's asymptomatic on remission. His lab work back to normal, and his fecal calprotectin now is 470. So how would you treat this patient now? Leave the patient on azathioprine, repeat a course of prednisone, switch immunomodulator to methotrexate, or initiate anti-TNF therapy? Please, if you can vote.
We don't have.
You have a vote?
We don't have entity.
There's something.
The last choice was not.
I see.
So we have 3 choices.
So you can maybe repeat
We
the
have
vote?
3 choices. The last choice is not.
Okay.
Here now.
All right.
Yes, sir.
Okay, can you vote now? So Who vote to initiate anti-TNF? I need only one and tell me why. It's the right answer, yani.
I am the
Okay, so why?
because he's already. I think the fecal caliber did not drop to the original.
Exactly. So remember, we said there is disconnect between symptoms and the inflammation. So in this case, if you use treat to target strategy, according to M study, it's better to escalate the treatment. Because although he's asymptomatic, he's feeling well, but his calprotectin is more than, there's a question about it, so I will ask you, is more than normal, let's say. Initiate anti-TNF therapy is the right answer because of that. Of course, if we just leave the patient as it is, we won't reach the target of inducing complete remission with mucosal healing. Repeat course of prednisone, that can be a good answer in case if the patient is not optimized to have azathioprine as a full dose, or if he's not tolerance to azathioprine. Same thing with methotrexate. If he has, it can be an answer. You can try that, but it's not the best choice. So azathioprine is the best choice. Afwan, biologic is the best answer. So patient has pre-biologic workup and starting on adalimumab, 160 milligram, 80 milligram as an induction, and he discontinues his azathioprine. He's instructed to contact the IBD nurse after induction to ensure he's tolerating the induction, and if he has any recurrent in his symptoms, he transitioned to adalimumab 40 milligram every other week, and he's scheduled to return to the clinic in 6 months. So how often would you repeat biomarker as part of tight control strategy? All right. So majority every 3 months, which is the right answer. Usually we repeat it every 3 months, and this is what has been used in CALM study as well. 6 months is acceptable, but we recommend 3 months. While every month is really just, it doesn't, it's too much. Even the mucosal healing wouldn't reflect in biomarker in this short time, while in contrast 1 year is really long time to follow up. So 3 months is the right answer. So the patient continue on adalimumab 30 milligram every other week and remain asymptomatically well. He has repeat his small bowel ultrasound, which showed mural thickening 4 millimeter over the length of 15 centimeter and no increase in Doppler signal. His fecal calprotectin now is 184. So what is your target level of fecal calprotectin? Less than 50, less than 100, 500 to 50? Okay, so the majority choose less than 50. Less than 50 is very sensitive, but it's not very specific. Same thing with 100, while 500, more than 250, is actually still there is a disease, there's mucosal injury. Therefore, the cut of 250 is recommended to use for this patient. And this is the cut also to treat to target that was used in CALM study. So the right answer is less than 250 actually. So the patient has a repeat fecal calprotectin at 9 months, and it retains as 380, more than 250. The patient remains asymptomatic and he has had no other change in his medication, including his NSAID. So what decision would you take given this result? His biomarker showed more than 250 calprotectin. So would you switch class of biologics, repeat fecal calprotectin in 4 weeks, see patient in clinic 3 to 6 months, or optimize anti-TNF therapy? Okay. Still going? All right. So the majority choose to optimize anti-TNF therapy, which is the right answer. Make sure the patient is taking, his medication, his biologic and optimum dose, and then see the response without jumping to another biologic or change the strategy, or without leaving the patient based on this calprotectin. So optimizing either, yeah.
Would you have another option here?
In this particular case, there is no, there's no other choice. What is in your mind?
Would you use
Monitoring, but his calprotectin came after 3 months is 360. With 3 to target, with a tight control, the recommendation is to optimize his biologics, because remember, biomarker, they reflect the mucosal healing. So if he has 380, that means there's still some mucosal injury. Yeah, drug levels is So drug levels is a good the answer actually, to see if he's optimized or no, and then from there you can jump to escalate. Yeah, Dr. Riyad.
Well, it's probably related to optimizing anti-TNF, but I think you should measure the trough level.
Yeah, this is what Dr. Abdurrahman was saying. So measuring it, and then from there, if it's suboptimal, you think about escalating the management. Yeah, I agree, totally agree. So providing that we did that actually, so that was not optimum, and then trying to optimize. So it's under the umbrella of optimization. So the patient was escalated to adalimumab 40 milligram weekly, and a repeated calprotectin 3 months after his dose adjustment was normal, 85. When would you repeat the endoscopic evaluation? This is a question was asked in one of the lectures. So you don't have choices? Okay, no worries. So if we say 6 months, it's very tight, but again, the patient wouldn't tolerate that. If you leave the patient without repeating endoscopy, it's not a wise actually choice. So the recommendation was anywhere between 1 year, around 1 year is a good choice to repeat the endoscopy. So you make sure that there is mucosal healing as well, to follow the treat to target strategy, and also not overdoing it, so the patient wouldn't tolerate that, and it is not cost effective. So 1 year is the right answer. Would you consider dose de-escalating in this patient? He's now fine, his biomarker is great. Would you decrease the dose of adalimumab?
You have to mention how far after being.
Can I go back
Well,
from here?
the time frame.
Yeah, so that was after 13 months.
Okay. No.
Then we
From
escalate
the
the
time.
Okay, so so I think that was from optimized anti-TNF therapy was in 10 months, and then after 3 months.
From that.
Yeah, from that. Okay, so the majority said no, which is the recommendation. So there is the risk of relapse if we de-escalate, because he wasn't that dose. Was it the trough level? Was it good? we escalate, and then the patient responded. To de-escalate, there's a risk of relapse. So the right answer is no. How would you continue monitoring the patient in long term? Not monitoring beyond a year. Continue to monitor fecal calprotectin every 3 months. Continue fecal calprotectin every 3 months, and periodic endoscopy evaluation 1 to 2 years. Susan, we spoke about this and obvious. So yeah, and that.
Just to add a comment.
Sure.
I think based on the STRIDE criteria, if your patient is stable and you've induced remission and you make sure that the mucosal healing is done and he's doing fine, I think we could repeat the calprotectin after 6 months. And 3 months again, perhaps in my opinion, is probably in a very stable patient with mucosal healing is
Too tight.
not too tight. I mean, it's
Too much of repeating
the
that.
recommendations of 6 months.
Recommendation is 3 months in the CALM study. Now the treat to target
That's why I
size.
asked you about the period. If you as to when, on the long-term basis, depending. I think if you go beyond 9 months to a year, and the patient is doing
Yeah,
fine,
three.
then
Yeah,
every 3 months is going to be too much.
yeah, I agree. 3 to 6 months are they're recommended, but they prefer every 3 months for a tight control.
For how
But
long? For how long?
well, they didn't
I mean, the
put it.
CALM study
Yeah.
was for a year, right?
Yeah, but they didn't recommend any time, and this question actually an answer was by an expert based on CALM study. Yeah, yeah, the prof. Yeah.
I don't see a point of repeating endoscopy if the patient symptom less and his calprotectin every 3 months is normal.
I would agree. This is what I do in my clinical practice.
To know endoscopy, unless he passes 10 years, then you talk about something else.
I would totally agree, but we are talking about the treat to target. The recommendation about it is to repeat every year or so the endoscopy, just to make sure mucosal healing is there. It makes sense that biomarkers are normal, so we know.
If you have done it after 1 year and you found that the patient has very nice mucosal healing, and then you keep.
I agree with you. This is what I'm saying. Yes.
A point of repeating it.
Yes, this is what I'm saying. But based on CALM study and their recommendation, which this actually answers and questions, and this real life case was based on, the recommendation was to repeat after 1 year, just to know to see the mucosal healing, to have a look. But I would agree that in clinical practice is actually I don't do that actually. I don't repeat the endoscopy every year, and we can hear from other experts as well.
Can I comment?
Yeah.
Treat your target. The advice also difficult to advise your patient to do endoscopy while he's doing excellent. So one thing to treat your target strategy to do cross-imaging study. So cross-imaging like a CT scan or MRI, I think is one option here. Can be used.
Can be used, yeah. As an option can be used. However, the question was about endoscopy, but the imaging can be used, especially MRE. They are recommended because CT is actually high radiation for the patient to keep monitoring on that, and ultrasound is not widely available, and it's operator dependent as well. I agree, but the question was about those specific scenarios. So about repeating endoscopy, who has any comment? Every year?
Just go back to that scenario, not for this case.
Yeah.
For this,
Yeah.
part. We decide to start biological therapy based on calprotectin only, without repeating endoscopy. Would you just start biological without doing endoscopy at that time?
What biologic we would?
No, I mean, based on the calprotectin level, we decide to start biological
Yeah,
therapy,
yeah,
but without performing endoscopy.
yeah.
So this is the correct.
Yeah. This is correlate biological actually as a biomarker correlate with mucosal healing. So we did a scope not long ago for this patient before starting him in biologic based on the calprotectin. So yeah, I would start the patient without doing another lock in colonoscopy. For every 1 year, this is a long-term strategy. It's not to it's not the patient is symptomatic or he's suffering still from the active disease. He's completely on deep remission, actually. Not deep remission. Deep remission, I would say, we need to have a mucosal look to judge. That's maybe the need of scope came from.
Can I just add that? One
Sure,
more thing?
yeah.
I think what answers your question here is the correct level that was done. Because that's incorporating two things. First, the patient was below therapeutic, and this is why the dose was increased in combination with.
No, before increasing, Prof, before increasing, his question, before increasing, just starting adalimumab.
In normal scenario, even the if you do calprotectin,
Yeah.
and the calprotectin is elevated,
Is elevated?
you need to make an action.
I need to make an action.
Your action would be the next thing is to do the
Yeah.
level to see if the patient has antibodies to optimize it. So obviously, I would do this before embarking on doing colonoscopy.
Yeah, I wouldn't do colonoscopy to see because I know there is inflammation. So the patients remain on adalimumab weekly because we escalated the dose, and the patient remain in symptomatic remission with no bowel movement per day and no abdominal pain. The wrist and knee pain have disappeared, and he has gained 7 kilograms in the year. Fecal calprotectin remained at 85, and repeated small bowel ultrasound and endoscopic evaluation performed in August 2017, and 1 year follow-up visit. And I think this is the last of our questions, and he was continued to be a normal parameter and asymptomatic throughout his visits, and scheduled to repeat colonoscopy 1 year after that. So the long-term goal remain mucosal healing, halting progression of disease, and normalize quality of life. Mucosal healing alters important long-term outcome, and a treat to target strategy utilizing the tight control strategy with fecal calprotectin will aid in achieving these goals in this patient. So I think this is all about this case, and thank you for your contribution and discussion. If you have any questions.
Yeah, one last question.
Sure. Thank you very much. Just, I will challenge this approach actually. Regarding the approach for the patient, after failure of steroid and azathioprine, I think there is a role for laparoscopic ileal section. I know the segment is a bit long, it's 40 centimeters, but there is data from 2016 saying that it's comparable cost-effective wise LUC per section versus anti-TNF. And there is data in October this month in the gut saying that it's more cost-effective to go for laparoscopic ileal section compared to anti-TNF for patients with limited
Localized ileal disease. Yeah.
So,
Yeah, I would agree with that. But if we are talking about this scenario with these options, medical management, then the right thing is to escalate the treatment. Surgical options, especially its longer stricture, as we say, it can be an option, but then the patient might have inflammatory, not fibrosis. Yeah. So, and this is what the case. He's taking gun with medical therapy. I see your point, and I think I would agree with that if the patient agrees based on this recent data. The question was the magic?
Yeah, so it's at 3 months follow-up, the patient is symptoms free, and fecal calprotectin came down from, let's say, 1500 significantly, but still above the 250 cutoff that you mentioned. Would you measure the drug level? And if they are therapeutic, would it change to a different class?
Well, if it came down from that high, for me personally, I would wait and repeat the calprotectin as well. So to see if it's improving, you said more than thousands, right?
Yeah, so the cutoff is kind of relative thing.
Yeah.
Coming down, patients free.
Yeah, I would
wait longer.
definitely wait. For me, I would definitely wait and repeat calprotectin in a month or so and see if it continues going down. Then that means the patient is responding. Why would I change my strategy based on that? But if the patient came with persistent calprotectin is high, then yeah, I would intervene. This patient calprotectin was 700, went down, normalized, and then went up. But your question is from thousands dropped to more than 250 in 3 months. I think we have to give a patient a chance. Yeah. Thank you very much.
One more question on the screen. If you go to iPhone, still there is one question on the using of the tool. You get the answer.
Still, there was one question in the tool. It was not mentioned by the tool, but for the company. Yeah, will you use this tool for monitoring every payer?
Not in my screen.
They forget to put it in your presentation.
No.
I disagree.
Thank you.
We disagree.
Well, I agree with that.
Thank you very much. Thank you very much. I think it's great.
Yeah.